We're going to pull up information again for panel questions, just like earlier this morning. You can, let's see. We have the instructions there. There we go. So at the top, again, you can join by web or by text and send your questions in. While we're waiting for those, I'll just say that I think it was about 3 years ago that we started these multidisciplinary sessions. So obviously we had maternal fetal medicine this morning, nephrology this afternoon. This is at a GI and hepatology course. I think we've had endocrinology, we've had allergy, ENT, and others join our course for these multidisciplinary discussions. And I think it's valuable because a lot of what we do is multidisciplinary, both inpatient and outpatient. I mention it only because you'll have the opportunity to, review our course at some point to get your CME, and if there are topics or any ideas that you guys have for future lectures or multidisciplinary sessions, let us know. While we're waiting for questions, I'll also just point out that we have one session left, and we hope many of you can stay around for Dr. Bilal, Dr. Mune, Dr. Clem, and Dr. Davis's talks. We will end the day with a rooftop reception, and it'll be an opportunity to mingle. I don't think it's going to rain during that hour, and we'll have refreshments upstairs, so rooftop of this building. So hopefully you can stick around at the end of the day for that. So we'll take a couple questions here and then move on to the next session. So you guys can decide who's going to take each of these, or you can each comment. But the first one, what are the indications for simultaneous liver kidney transplantation in patients suspected to have irreversible kidney injury?
So we have like a set strict guidelines that I think we had in one of the slides. So it depends. The commonly, if you're dealing with acute kidney injury, so if you have like a 4-week period in which you have dialysis at least once during that 4-week period, you can benefit from that combined liver kidney. And also we have like the CKD criteria in which if you have like a 90 days of consecutive having a low GFR below 60, and then at the time of eval your GFR is like below 35, that will be another indication for SLK. This is not a question, but like as a group and as we work together, we are trying to move potentially more to our safety nets in the cases, or at least discussing it with patients. In many instances, patients do benefit from a liver, but that kidney for X or Y reason is not good or it's not viable. So we are trying to explain to our potential SLK recipients that there's a possibility that they might end up with a liver alone, but the safety net kidney is still very viable or usable after. So hopefully that answered the question.
Awesome. And then when a patient has both sepsis and cirrhosis with AKI, how do you decide whether HRS physiology is contributing enough to justify vasoconstrictor therapy?
It's a great question, and one that we encounter a lot. I think it gets easy when they're in the ICU in septic shock, and your classic shock protocols really cover a lot of what we do in those first 12 to 24 hours in individuals with HRS. Volume expansion, and in that case, they'll have vasoconstrictors initiated already. When it gets tricky is when you have patients that are on the floor. I usually use the clinical scenario to help me a little bit. So if someone has tense abdominal ascites and they have SBP, I'm more likely to put HRS physiology at the top of my differential once you've kind of volume expanded them from the impacts of their infection, and be more likely to initiate vasoconstrictor therapy earlier. Now, sepsis from another etiology, pneumonia, for example, it's a little bit harder to position HRS physiology as the primary etiology of the AKI, and you may be slightly delayed, recognizing that this is also a continuum, that any infection can really tip people over the edge. But that's how I would start to approach it. I think some clinical settings are harder than others to make this distinction. And what we tried to point out is that they probably have pre-renal AKI in addition to the HRS physiology going on. And all of those things can kind of exist. And parsing those out, usually you can do within the first 12 to 24 hours. And you really haven't, by guideline standards, missed a window for initiation of vasoconstrictor therapy. Do you have anything to add? You have way more experience.
No, I think it's that the timing would be key. And in terms of the vasoconstrictor, you can usually justify using levo nor epi in sepsis related of what cause. Same for the volume resuscitation and that time frame or that waiting, that initial 12 to 24-hour period in which the patient's clinical course will evolve will definitely point at what is the main driver. Knowing that coexistence can occur, but if it's an infection and you notice some improvement after like a day of antibiotics, then you got your answer versus not.
This is a good question. Are you reading the questions?
Yeah, sure. Yes. So when is it recommended to resume diuretics after resolution of HRS-AKI? And any dose preference?
There are no perfect recommendations. What I will say is, in my mind, before I started my year of transplant fellowship, I thought that there's no way that you could have someone with HRS-AKI on a diuretic. But I will tell you that if you have people with adequate MAPs on terlipressin and norepinephrine, that it is totally appropriate to resume diuretics, even though you are functionally treating them for a kidney injury. The right answer is to stop all diuretics in the first 24, 48 hours. Home diuretics, there's no rush to restarting those. So you can certainly give people a minute to level out. Usually this is, again, there's no guidelines. It's going to go a little bit to provider preference. Sometimes we'll just restart their Lasix and not their Lasix Spiro. Sometimes we'll just start their Spiro, depending on kind of what their physiology is. And so I don't know that I can give you a perfect time and dose preference, but start low and slow, and don't be afraid to start one and have close interval follow-up in the outpatient setting where you resume their second one. But also don't be afraid to use diuretics in people if you are adequately perfusing their kidneys, because these patients are really volume up. And so we encounter this a lot.
I agree. Once you're able to restore the renal perfusion and that urinary output increases, that's probably like the total sign of that you can potentially go by resuming the diuretics, noting that that volume overload and that congestion might per se cause like further issues like a renal type syndrome in which we have volume overload and with diuresis, and that actually improves their urinary output. So it's kind of that scenario. Once you think that you have reversed or restored that renal perfusion, that's probably the time where you can consider resuming diuretics if clinically warranted.
Realizing that the topic of determining transplant candidacy would be a whole lecture in and of itself. But is there any benefit in a patient who's not a transplant candidate to using terlipressin or norepi versus octreotide plus midodrine for HRS?
So I think it comes to one of the last slides that we talked about. Are we doing this as a bridge or as a utility? So if you're thinking about not a transplant candidates, you have to think about what your goals are. If you're trying to wait, like I said, you're waiting for a family member, or it depends on your ultimate goals of therapy where you should use it or not. But if the patient is on hospice and everything else, you can consider using a go by for comfort, but again, it might be futile. So it's more of what are the patient's ultimate goals of care, which might dictate using it or not. In terms of benefit, I don't think there's any major clinical benefit.
Yeah,
And in the community, sorry.
Oh, no, go ahead. I was just going to say this concept of futility of these agents comes up a lot. It comes up when we also talk about renal replacement therapy in these patients. I think the transplant candidacy is nuanced. It's hard for us to project what individual goals of care are. I mean, the goal is to get people out of the hospital. People can get out of the hospital on terlipressin or norep, a trial of those therapies, then great. Now, if they're not responding and their serum creatinine is rising, then you have a very different discussion with someone. But I think ultimately transplant candidacy is a fluid decision in some cases. And so time is often on the patient's side, especially when we think about our alcoholic liver disease patients. I think it's hard to say that they wouldn't benefit from the opportunity to leave the hospital and do the things that may be required of a transplant evaluation.
Thanks. I'll just throw in a question since it comes up all the time. Regarding transplant candidacy, if someone is not at that moment considered a transplant candidate, would you ever offer them a time-limited trial of renal replacement therapy? Perhaps if they're able to get out of the hospital on intermittent HD, just as an example.
So
then, go ahead.
I think that's the key. Can they tolerate conventional or intermittent dialysis in the community by their hemodynamics, that's usually the biggest holdup. In terms of many units will not accept your patient if you're not tolerating hemodynamically. They won't even get accepted. So that's usually like the rate limiting steps in these patients, which you think they might benefit from waiting, as Braidie had mentioned it, Dr. Campbell mentioned. But more often than not, the community dialysis are not willing to accept these patients who are not tolerating any ultrafiltration because of low blood pressures and they don't have the capability of using levo or other medications, or midodrine is not working. So that's usually like the limiting factor. But if they're hemodynamically stable and tolerated, yes, we can consider that.
Then if someone's already listed for transplant or they're a candidate now, why do you want to improve their renal function? So their MELD score is just going to go down.
So that's a very
Catch
That-
22.
that's a very good question. It is more of like a symptom managed too. At some point, if you cannot manage that volume overload, even if you're a transplant candidate, you don't know when that organ is going to come, and if you don't use it, then the patient might go into respiratory failure. And same for the other electrolyte disturbances. So I think there's going to be clear-cut indications, even if you're a transplant candidate, when to pull the trigger, and you should follow accordingly in the current clinical scenario and patient's best interest.
I thought you might say that.
This is why multidisciplinary discussions for all patients are very important, Dr. Kalra.
And so the last question then, who should lead the care? You, Dr. Campbell, Dr. Giusti, together? Should it be one person? How would you?
I'm gonna say both. That going to the initial start, I was kind of sad that my cardiology joke didn't land it, but I didn't realize that there's no other kidney or heart pips here. But I think it's both. It's hard because you cannot predict when you're gonna tip over in terms of renal failure in dialysis. I'm sure that my colleagues are more than capable of managing diuretics and other stuff. But if you have a combined approach, you are I think it should be both, and that will probably guarantees it's in the patient's best interest to have that combined care. If it's the liver, the main driver, maybe the GI can be the captain, but at the same time, we should be working together.
This is not a unique problem to community setting. We encounter this a lot here at our institution as well, about who should lead what part of it. I think both divisions offer a unique perspective, and one of the perspectives that as hepatologists we can offer is the discussion of transplant candidacy. And so obviously resources are limited and we are the resource, but it is important that we're involved. I think we miss the opportunity to help patients.
That was great. Thank you very much again, guys. All right, session 4. And then we'll be handing out one of 10 $100 gift cards. Yep.